Hello, everybody. This is Mark Lynn with Healthcare Business Specialist in Chattanooga, Tennessee. And this is the preparing for the RHC certification, inspection, or re-inspection. If you've already been a rural health clinic, this is being conducted by Healthcare Business Specialist in Chattanooga, Tennessee. And we are sponsored by Azalea Health and ChartSpan. And we have and so today's date is February the 5th, 2020. Here is my contact information. There's my picture. If you need to get a hold of me, I think by now most of you guys know me and can get a hold of me by calling that phone number. Dani Gilbert is online with us as well, and she'll be helping me out with this webinar, and she'll be handling the poll questions as well. So we will move on. We are Azalea and ChartSpan is back on board with us again this year for having our sponsoring our seminar, so they will be free to everybody. There's our tentative dates at the end of the year: Nashville 11/5, Somerset, Kentucky 11/12, and somewhere in Alabama, probably Clanton again, but that will be 11/18, and we are planning on adding some more locations for that. We may be going to Georgia, we may be going to Arkansas, but we are working on adding some locations there. There's what our Google Doc looked like with our schedule for last year, and it'll be probably something similar to that, although we may add a little bit more billing this time around because we sort of went easy on billing. What does Healthcare Business Specialists do? We prepare about 175 cost reports every year. We do a bunch of RHC startups. We do emergency preparedness for RHCs, especially if they've gotten surveyed and they've got a condition level deficiency and they need to get it done quickly. We're able to do that and respond to the state pretty quickly with that. We usually get about one of those a month where we have to do that. If you're in Tennessee, we prepare those TennCare quarterly reports as well. And there's a listing of all of our services here in and then this Google Doc as well. If you've not already joined the Facebook group, please do that. We have about 1,020 something members now, and it is an excellent resource for information. It's I learn something on there every day as well. Just not only do you guys learn something, but I do too. So it works out really well. Here was what our presentation from Clanton, if you wanted to get the slides from that particular one. There's a lot of good information in there as well. Questions or comments, probably the best way to do that is over in your questions bar. If you'll type those in, and then we will stop as we go through and answer those at appropriate places there. And Dani, you can sort of, if you'll watch those for me, and if there's a good time to break in and ask a question, please do so as we go through. We will probably have a little bit of time. Most of these sessions here, if you've been with us lately, have been running over. I've not kept to my 45-minute webinar number there, so it may go a little bit longer than that. They tend to do that. Disclaimer, this is being recorded. We will put this on that Facebook group page. We will put this on our website, and it'll be on YouTube. So if that's an issue, then please hang up and go away. Don't go away, man. Just go away. I don't know why that would be a problem with some people, but we do that. Also, I forgot what was it. Oh yeah, everything is current as of today. I worked on this thing most of the morning, and so everything should be updated. In fact, some of the slides have changed probably since the time I sent it out. So when do RHCs get inspected? Upon initial interest into the RHC program. One of the reasons why we did this one this time was because we have a bunch of people that are waiting on their inspection, and I wanted to go ahead and instead of me driving to where they are and telling them some information about ready for the inspection, I wanted to get this webinar updated for those people as well. So that's you're getting into the RHC program, you have to pass this inspection. Also, if you've been in the program for a while, then you are subject to recertification. There will be an unannounced survey in most cases where the state will show up, depending on what state you're in. If you're in Tennessee, Alabama, Kentucky, most of those states, it's usually about 5 to 6 years. If you have Quad A or the compliance team, they have a pretty they have a more regular schedule, is my understanding, and I think it's every 3 years they come out and do their contracts are typically 3 years, and sort of when you get ready to renew that contract, they will come out and do a recert survey for you. And I think Elsie's on here, so if I'm wrong, Elsie, you can correct me if that's not the case anymore. We do have questions. Everybody likes the questions. I know we did the billing webinars. Everybody like, oh, we love the questions. So Dani, if you'll open up the polls here, we'll have our first question here. Probably not the most important question we'll ask today, but how many conditions of participation are there in the RHC program? A, 4, B is 8, C is 9, and D is 12. And let me go over here and open up the look at the polls. I'm going to cheat and look and see what you are answering. And 42% of you guys have voted. So let's be like Iowa. Just don't be like Iowa. Pick up the pace here, and we'll get your votes in, and hopefully we can get them counted faster than they can count them in Iowa. So I'll let it go another few seconds here. Let's get to about 50 seconds, Dani, and then we'll close it out. All right, and then you can tell me the results.
Yep, 14% said A, 24% said B, 45% said C, and 17% said D.
Okay, and like I said, probably not the most important question there is, but there are 9 conditions of participation. Used to be 8. You know, we talk about the 8 conditions of participation. Now there is 9. Emergency preparedness was added to that a couple years ago. So that's the 9. There's 9 conditions, and we'll show you what those are in a minute. What is the objective of the RHC certification or recertification inspection? It's basically to see that you're in substantial compliance with all 9 of those conditions of participation to be a rural health clinic under Public Law 95-210. That was approved in 1977. The first RHC actually was in Rogersville, Tennessee, March the 1st, 1978. You could receive a standard level deficiency or a condition level. A condition level means that whoever the inspector is, if it's the state or Quad A or the compliance team, they will come back out and resurvey you for that particular item that you're out of compliance. One of the biggest issues we've had, again, is emergency preparedness. Is people did really good 2 years ago when emergency preparedness first came out. It was actually, I think it became, what was it, November the 15th or November the 16th, 2017, it became enforceable. Everybody became really good at it, and then they forgot about it. And when the state surveyors are showing up, they're saying, we haven't done anything in 2 years, and people are getting condition level deficiencies for emergency preparedness. We're seeing that a lot. In fact, I've got a tabletop on Monday where we have to do a drill for a clinic, and the state inspector is supposed to be back in 4 or 5 days after that. So we got to really get it done. So because there's very tight time frames on that, you have 30 days from the date your plan of correction is accepted when the state will actually show back up and resurvey you. And Quad A and the compliance team, I believe, do exactly the same thing for that. Here are these 9 conditions of participation. Go to this. This is the official spot for this, even though it's on the Cordell Hall. This is the Cordell Hall. Cordell, you can tell from Tennessee because we go to the Cordell Hall building for TennCare all the time. But Cornell EDU, they have the E documents here, and you can read this whole thing in less than 15 minutes. In fact, a client called me, emailed me this morning with a question, and I had to look it up in these regulations, and I read the entire thing in less than 15 minutes. There's not that much to it. It's bare bones skeleton of the regulations. That's why it's a little bit complex sometimes to comply with these rules, because there's not a whole lot of actual law that's out here. And we have put together something called an RHC conversion guide with a lot of helpful information in here. So it's a Google Doc. And if you click in here, these are workable links here, or what they call hot links. And if you click on those, you'll go straight to that. I'm not going to click on it because we'll go right there, and we don't want to do that right now. but it has a lot of information about preparing for the RHC survey there. So you definitely want to take a look at that document if you guys are becoming rural health clinics. That's going to be extremely, extremely helpful to you. And then we have a lot of resources on our website called ruralhealthclinic.com, certification materials. In fact, the recording will be here. This is a place marker. This is not I didn't go backwards in time or forwards in time and record it and put it there, but there's a place marker for it. There's our PowerPoint presentation for today. And then the mock inspection form. There's a PowerPoint presentation that Kate Hill did on RHC certification, and then Elsie Crawford has done one that's really good on RHC certification as well. So you get information from them, and I stole some of their slides, so I'm sorry, but it's really good. So they provided really good information for that. So we get it straight from the authority when we use people like that as well. So that is a good place for you guys to find information as well. This is not all what's on here. There's a ton of information on this website for you guys. It's all free for you guys to get it. When you are becoming a rural health clinic, the first step that we do is we fill out an 855A, and that will go into the Palmetto or CGS. That's the typical ones that we deal with in this particular southeastern area. And it takes about 60 days for that to be processed. What happens though is you don't sit on your rear end and wait that 60 days and then start working on preparing for the state RHC. As soon as you get that 855A in the mail or you submit it by PAYCOS, then we want to start working on preparing for the state inspection, or if we have to hire Quad A or the compliance team, we want to start working on getting ready for their surveys and hiring them to do that. There's certain states that will not come out and do state inspections, and you'll end up having to hire either Quad A or the compliance team. I know we started working in Florida, so we're gonna have to get a hold of LC. We'll have to talk to you about doing a state inspection in Florida. Arkansas, they will not come out. Indiana, you end up Illinois. There's several states that they really will not come out to very quickly, and so we have to hire Quad A or the compliance team, which those are called deeming authorities. They can actually, when they do their inspection, they can make you be eligible for RHC reimbursement from Medicare and from Medicaid. When I go do an inspection, I basically am telling you what to look for from them. So big difference in what we can accomplish for that. So you want to be started. This is us starting on working on the state inspection. So we're preparing for it. And then our next poll question is opened up here. If you've been open for more than 1 year and are becoming an RHC, so you're not one yet, do you have to do a program evaluation and have it completed before the inspection? And A is yes and B is no. And give you guys a few minutes to vote here. And we got 50% voted. Danny, we'll give them about 15 more seconds. And then we'll see, and then we'll close it down. Maybe we'll have the results before the Iowa Democratic Caucus at this point. Okay, Danny, what's our answers?
76% said yes and 24% said no.
Okay, and the yeses are correct. If you've been operational as a clinic for more than 1 year, as of right now, and this may have changed with these new regulations that were published in November, that were effective November the 29th about program evaluations. But the rule that we've always used is that if the clinic has been open for more than 1 year, then you have to have a program evaluation for that. And so that's until CMS tells us differently, that's what we've been using as far as that goes. And it's not hard to do with the program evaluation. We will typically when we do our mock inspection, we'll go on site. we will we'll write up that report as a program evaluation and basically say, well, you know, we've evaluated your program and here's what you're going to need to do to be in compliance with the RHC program, and go through, and we typically write up a pretty long report saying here's what all we need to do to be in compliance. And then we look at some of the data that you would for the program evaluation. So the answer to that one is yes, you will have to. If you've been in business for less than 1 year, you will not have to do that, but you'll have to have a plan of how you're going to do that program evaluation coming up at the end of 2 years. Now you have to do a program evaluation every 2 years according to the new regulation. So here are the steps for RHC for getting your RHC ready for the survey. Number 1, you're going to need an RHC policy and procedure manual. Number 2, you're going to need an emergency preparedness policy and procedure manual as well. We have those as two different documents. You could probably make them one, but the emergency preparedness manual, policy procedure manual that we have, it's about 170 pages. Our RHC policy procedure manual is probably that big as well, maybe a little bigger. So we just made them two different documents, and that works very well. Third thing you want to do is start training your employees about RHC status. You're going to be giving them some forms. You're going to be making sure that your HIPAA is up to date, that your OSHA, your airborne pathogens, all of that type of training is up to date for the surveyor when they come. And then you want to start acting like you're a rural health clinic. Just because you have a policy procedure manual and you're not a rural health clinic yet, you need to start implementing the forms. We provide you with a bunch of forms for you guys to start using, and about a couple months before the state surveyor or Quad A or the compliance team shows up, you want to start using those forms and just acting like you're a rural health clinic, because whenever that inspector comes, they're going to want to have something to review. And then you're going to need to conduct an emergency preparedness drill. Right now, you only have to do one per year in a rural health clinic. We have a tabletop setup. We typically will do a tornado drill. You will have to do what's called a risk assessment. And a part of our tabletop drill, we will do that risk assessment as well. We use the Kaiser risk assessment, and we'll do a poll, just like we do here. We'll have a poll where we say, how were we right or were we wrong about your particular area, and then we'll fix the risk assessment from the result that you have. We'll also use the risk mitigation plan for your particular area, and we'll use input from the local EMA directors. I just got off the emailing an EMA director to be at our webinar on Monday. So we try to rely on them as well. And then we have a test as well for your people for an emergency preparedness, and each one of them will sign that test, and they'll provide contact information that will go in their emergency preparedness policy and procedure manual. Again, we will conduct that program evaluation if you've been operational as a clinic for more than 1 year. We will come in and do the mock inspection. And then again, I'm telling you the way we do it. Other people may do it a little differently, but it's probably, I think everybody pretty much does the same thing, because that's what you have to do to be ready for an RHC inspection. So we'll conduct a mock inspection where we'll go through and make sure you're doing everything you need to, and walk through the clinic and see, just sort of get a good look at everything. And then what you want to do is prepare an evidence binder, and you'll have one copy will be for the state inspector or Quad A or the compliance team. So when they walk in the door, you can hand that to them. And then you want to have a notebook where you're going to keep it forever, and sort of keep up with it as you go along, keep it updated as you go. That evidence binder will be something you want to keep up to date. So just in case the next time the inspector shows up, you'll have it for them. Here's what we do. When we do a startup, we have what we do is we'll have what's called a kickoff webinar, and we sort of give people things to do and spell out the process. So this comes from that particular session there, of just a listing of things to be done. Dani, it looks like the question mark has sort of popped up on my screen there. Do we have any questions?
There's a couple. Somebody asked, what is the program evaluation?
What is the program evaluation? That is a good question. A program evaluation, it's typically, it's going to be a meeting between the medical director, a nurse practitioner, or a PA, and then a community member, somebody that's not employed by the clinic. And there's certain things that you have to do every other year. You have to review your policies and procedures. You're typically gonna look at the number of services that you guys have provided, and you're gonna make recommendations for changes, and then you're gonna make a plan for implementing those changes as well. You would typically do a walkthrough of the clinic, and you would review a certain number of medical charts. We review a certain number of active charts and a certain number of closed or inactive charts. And then we put together a nice big report for that. And then you guys would sign off on that and put that in your evidence binder. And if you want to put it in your policy procedure manual, that would work as well. But I typically tell people put it in your evidence binder for whenever the state inspectors show up. So it's a very good question. Next question, Dani.
Well, the other one just said, I thought you said they moved that to 2 years, and you covered that when you said every other year. So
yeah, every other year. It's every 2 years. Yeah, that's right. So okay, all right, very good questions. And you have to watch me occasionally. I will say annual valuation because I've been saying annual valuation now for 30 years. So it's hard to teach old dogs new tricks sometimes. So here's some questionnaires that what we will do if we're working with you. Again, I don't know what other people do, but we will send you out a policy procedure questionnaire and emergency preparedness policy and procedure questionnaire. And if you'll fill those out, then we will draft up everything and then send it to you with a Word document with a Word file on there, and you can change it as well. And if you're not one of our clients, we do provide the emergency preparedness policy and procedure manual to you guys for free. You can just go on this ruralhealthclinic.com emergency preparedness, and there's some documents on there that will help you do that. We do not provide the RHC policy and procedure manual for free because we have a lot of people out there that, you know, they make a living off of those things, selling those, and we don't want to give that for free out to people. So just as a courtesy to everybody else. HBS, we do have some OSHA, HIPAA laboratory manuals. You want to make sure that you look at your manuals, make sure they're up to date. And if you need those, we provide that to the ones, our clients as well. But if you don't have those up to date, you probably want to look at those and make sure you're doing everything up to speed on your OSHA, HIPAA, and your lab services. What your policy and procedure manual should focus on is really those 9 conditions of participation and the policies related to it. One thing that I found from going out is a lot of clinics have a lot of processes and a lot of procedures in there, and they cover everything. I was at a clinic the other day, and my goodness, it must have been 12 inches of paper that was their policy and procedure manual. I've never seen a folder this big. And what I found was they had all sorts of processes. They had everything from the abbreviations to use to how to tape toes. They had a table of contents that must have been, I think it was 12, 14 pages, single spaced on every single process, from how to answer the phone to how to write off a bad debt to what to do on your cost report. And really what we focus on is looking at those 9 conditions of participation and having a policy and a procedure to comply with that. I mean, it's great to have all those other processes and procedures outlined, but you can have a financial management policy and procedure manual. You can have a human resources policy and procedure manual. I would not put that in with the RHC policy and procedure manual because it's just going to make it harder for that state inspector or Quad A or the compliance team to determine, did you hit those 9 things you need to do? And it's going to slow you down as you try to get ready for this if you haven't developed all of those financial policies, which I know a lot of these small clinics I work with, they would not have those types of policies in place. And so and you look at, just to give you some definitions, process is basically a shorter statement. It's like what happens, and then procedures are how to do things, very specific procedures on how to do things. So you can see how that would take a lot of time if you did every single process that your clinic does, from accounts payable to protocols, to every single thing. It would take a long time to do every single process that you guys do. So in order to speed us to that process of focusing on what we have to pass this inspection, that's what we do. I'm not necessarily saying that's the right way to do it, but that is absolutely the way to get you there, the fastest way. And then you guys can continue working on getting all these processes out there. And I will say that our friends Patty Harper and Jeff Harper, they have a online policy and procedure manual that is really, really neat. And it's not very expensive. And you if you want to talk to them about purchasing that, I looked at it in St. Louis when we were at the NARHC meeting with Jeff, and Jeff ran me through the whole thing, and it was really awesome. And it's sort of like what we have. I know when Quad A writes us up, or the state or compliance team, when they write up one of our clients, we have a program called Asana, and Asana will actually send out, it has a way for us to send out emails in the future to remind people to do certain things. And Inquidocs has that sort of information in there, and it also tells when people have read the policies and procedures and have signed off on them. So it has a lot of neat features in there like that. So you may want to look at that as well. I know our policy and procedure manual, it's sort of a snapshot in time where it's sort of stagnant in that you just do it with the one time, while this Inquidocs, it's sort of changing. It's very fluid. So it's a very good product. I was very impressed. Okay, number 3, Dani, if you'll open this up. The question is, the most important step to pass an RHC inspection is to prepare and maintain a comprehensive evidence binder to present to the inspector. A, yes. B, no. And this is probably a subjective. There's probably no right or wrong answer on this one's more of a subjective thing, but to me, it's pretty clear that this is a very good thing to do. All right, Dani, I guess we can close it out. We've got 90, what's the answers now, Dani?
93% said true and 7% said false.
Yeah, it's that really, if there's one thing I can tell you, is put together a good evidence binder, so when your state inspector, Quad A, or compliance team show up, you can hand them that. That's going to get you so far along. It's going to be so helpful to you. If you do that one thing, then you're going to be very close to that. And so here's what we do in Tennessee. You get a letter, something like this one. Whenever they walk through the door, your state surveyor is going to say, "I'm here to help, and here's all the stuff that we want you to provide for us." Well, we already know that in most of the states. We've got one from Quad A, we got one from compliance team, we got one from Tennessee, Arkansas, Alabama. All the states that we tend to work in, we have that letter. And so we tend to put together an evidence binder for that particular entity there. So we put together, this is the table of contents for this one for Tennessee. And then here's instructions. Again, these are hot links, so you can go in there, your instructions on how to build your evidence binder. And then we have a table of contents that you can use as well. And then what we ask you to do is make your own notebook that you can put on your shelf and hang on to, but then put in an expandable folder all those copies of stuff that you put in your notebook. Put that in an expandable folder and then hand that to the inspector when they show up. That way, you don't have to start making copies for them. You can just go ahead and hand them that information and they can start working. The sooner the better. The faster you can get them in and get them out, the less chance you have for them to find things at your clinic. So not that we don't mind having them there, but the reality is that, the easier you can make their job, the easier they can make your job. And so here are some of the things that they would typically be looking for. If you know that the state or the Quad A or compliance team are coming, put together a schedule of your nurse practitioners, PA, certified nurse midwives, to prove that they're there 50% of the time. I know people always ask me, "Well, Mark, we don't have a W-2 for our nurse practitioner. The law says that you have to have 50%. And I'm like, well, I've been doing this 30 years. They've never asked for a W-2, but they have asked for schedules. They will ask for schedules on how much time that nurse practitioner or PA is physically there providing care. So you want to do that if you know you're coming up with an inspection very soon. There's other ways for them to prove that nurse practitioner or PA is there 50% of the time, but that is one thing that they tend to ask for. You want to have a listing of all of your licensed providers and staff. You should have a credentialing process every year that you go through where you verify that everybody's license is up to date every month, that they're not on that excluded list, and so you have credentialing processes. You want to make sure you have that list up to date and current, and make that available to your staff surveyor as well when they come. And then here's what our table of contents looks like. This is a tab. If you want to get the tab, you can modify it and change it how you want to. There's a hot link to get that as well. But that's something very important. Acting as if you're an RHC, that is something, again, you want to start doing that before. And what you want to do is assign duties to certain people. And this here is exactly the same link as before. But what we did is we put together a 25-page document where we assign duties to certain people. The medical director is going to do this. The nurse practitioners or PAs need to be doing this. Your nursing and medical assistants, your office manager, and then there are things you have to do every year. And what we did is we put in forms to help document each one of these. That's why it's 24 pages long. And what happened, we put little pictures in. So a little doctor-looking thing, that's a form that a doctor should be using. This is the nurse practitioner. This is our nurse. So we made it really sort of like kindergarten-y, but those forms will help you, and you don't have to use those specific forms. Those are just ones that we run across that are really good, that people have been using, and they work very well. So let's go through and some of the things that has to be done. The medical director should review and sign the policy and procedure manual, that's the annual program evaluation. I got to change some of these slides, but and then they should be reviewing 15 charts each quarter and at least one closed chart. That's what we've come up with right now. That number sort of changed. We're sort of shooting at a moving target on how many charts that the medical director should review. But that's really considered your quality assurance program. That is something that is done outside of the normal review of medical charts. Depending on what state you're in, there's a scope of practice for your nurse practitioners and PAs, and under that scope of practice regulations, the doctors should be reviewing. Sometimes it's 10% of charts, sometimes it's 20% of charts, sometimes it's no percentage of charts. A lot of nurse practitioners are operating sort of independent of the physicians now, but for rural health clinic compliance, what we've always recommended is reviewing a certain number of charts and then putting those in a little document called quality assurance, and then handing that to the state inspectors as well. So those are the 15 charts, and we're going to show you some forms that people use to do that. Update your collaborative agreement with your nurse practitioner PAs every year. Be there to review and sign your emergency preparedness manual. Participate in drills if they can. That would be awesome. They don't have to, but that's one thing we'd like to see. And then determine which emergency drugs are in the emergency kit. Those are some of the things the medical director should be doing. Here's the chart review forms. This one form here is sort of detail oriented. You may want to have a nurse go through and use that and sort of tick and tie this. And this is what I was called the A+ student here. This is the C- student over here, where you basically put the chart number, date of service, was things acceptable, do they have any recommendations, and then notice that the medical director will sign, your nurse practitioner will sign, and in both cases they will sign in these documents. So that's very important that they do that. I don't know if it's necessarily important that you tick and tie. Nowadays with electronic health records, I know when I look at electronic health records, they're so good, you rarely ever find an issue. The one thing that you'll find is that consent to treat. I know Quad A, when they do an inspection, they're going to look at 20 of your medical charts, and they're going to look at those consent to treats, and they have to be signed, witnessed, and updated within 1 year. And if they're not, you're going to get written up. And if you get 2 out of 20, we're going to have a standard level deficiency. We have to have a correction plan. And I'm going to have to send out these Asana email. I got to set the Asana email to send out reminders to do all this sort of stuff. So look at your consent to treats, and the state will write you up for this as well. They don't always look at 20. A lot of times they'll look at 10. Sometimes they look at 5, but they will look at some medical charts to see how many, to make sure your consent to treats are signed up. And also make sure that, I know another thing I saw the other day was injection site, is document the injection site, because we've got a lot of opioid abuse, especially in Kentucky, and they're very interested in knowing where there's injection sites are. Make sure you document that, because if you don't document that, then that could be some type of drug abuse type of issue there. So you want to make sure you document that as well. Here's what your nurse practitioners should be doing as well. Again, keep a schedule for them. It's going to be extremely important that you do that. Nurses, you should have pretty comprehensive checklists, especially related to infection control. You definitely want to do a cleanup of your clinics. I know a lot of you guys, if you know, I've had some of the older docs that are becoming rural health clinics, and they've been in that same place for 30, 35 years. They got a ton of clutter. You need to get that stuff out of there. It's really, because it's going to make it harder for you to pass the inspections if you have a ton of clutter in your clinic. Undergoing OSHA training, airborne passages, all that sort of stuff, you want to make sure they're up to date. Make sure you're able to do the 6 required lab tests, and then look through your patient rooms. There's a walkthrough summary that we have on things, on what the patient rooms should look like as well. Those are some of the things that the nurses do. The office manager, again, evidence binder, that's really the big thing you want to be working on. All your policy and procedure manuals, we want to get those up and ready for the inspection. And then doing your emergency preparedness, your drills, that stuff you want to work with us to get that completed. Preventive maintenance, if you're a small clinic and you've not had somebody to come in and do oh, my brain is going blank on this. Bluegrass Biomedical, that's one in Kentucky. Renew in Jackson, Tennessee. They will basically come out and look at any type of electrical equipment. They'll calibrate it and make sure that it's operating. Hang on to that invoice. Hang on to whatever information they give you on the serial numbers, because the state inspector, Quad A, and the compliance team will be looking for that. So, and of course, make sure all your credentialing is up to date for all your providers and for your staff as well. And here's some of the things you have to do on an annual basis. Again, we got a program evaluation that's every other year. Now, keep your emergency preparedness up to date. Most of the emergency preparedness stuff has gone to every other year. Work with whoever's preparing your cost report, hopefully be us, but work with to get your cost report done. Otherwise, Medicare is not going to pay you. And then review, update, and approve changes to your RHC policy and procedure manual every other year. I mean, I just change this to biennial projects is what I need to call this. And then again, conduct your preventive maintenance. Make sure you have a tickler file to do that every year, because it has to be done. Here is something that we've been getting written up. Quad A has written us up about 1,000,000 times on this. So by now, we should have this one down on the Quad A thing. Is you have to, and this is in the law. I just read the law this morning where it says you have to disclose medical direction, principal direction, and operation of the clinic, and you need to do that in the lobby. That's what we've done, is put together a little certificate there. Here's a click. If you click on the certificate, you'll be able to do that. And then the OIG and exclusions database. We just had this question on the Facebook Rural Health Clinic Information Exchange group this morning, and Patty Harper answered it, which she does a fantastic job answering it. So I basically just took her answer and put on here that, and I didn't notice in Kentucky, she says you have to do it monthly. I mean, Kentucky's very highly regulatory state. Of all the, Louisiana and Kentucky are probably the two most, and I believe in Tennessee, Louise was telling me that you had to do it every month as well. So that's one thing to put on your to-do list, is every month, check that exclusion list to see if that sorry Mark Lynn hasn't been excluded from the Medicare program. And we've had clients that have been excluded. The doctor has been excluded from the Medicare program from fraud or other types of issues that you could have. So you want to be doing that every month and documenting that you're doing that. So that was a good thing that Patty had pulled together for us this morning. Dani, do we have any more questions as we go along?
Yeah, you got a handful.
Okay, let's go ahead and stop for a minute and see what we got.
Okay. Somebody asked, from the evidence finder checklist, how do we get items 2 and 3?
Oh,
And I've got it pulled up. You want me to answer it?
Yeah, well, yeah, yes.
Yeah. So item number 2 is the CMS 29, and that is submitted with your state application. And Manuel, I've actually got yours if you want me to email it to you. And number 3 was the CP 575, and that's just the letter that you get from the IRS that has your tax ID number. And Manuel, I also have that on y'all if you need me to email that to you.
Okay. All right. And then, yeah, in Tennessee, they'll ask you for about visiting nurses, any approval for that. Nobody in Tennessee, nobody east of the Mississippi has that approval. So you just want to put NA on that for visiting nurses, unless somebody has it that I don't know about. Nobody has it. Okay, Dani, you got any other questions?
He actually just typed in and said item 4, which is the tie-in notice, and that's the letter you get when you become an RHC from CMS. And so Manuel, y'all do not have one yet.
Yeah, you'll get that one later on. That's after you pass the inspection. You'll get the tie-in notice, but that's just a placeholder for it so you don't lose it, because I know that's a pretty important document to hang on to as well. So okay.
The next one says, is the chart review per mid-level provider or per clinic?
They don't really ever give you a good answer on that one. I've been using per clinic. I've been using 15 per clinic. The reason why in the interpretive guidelines that came out in 2018, it says that at least 50 charts should be reviewed every year. And so I said, okay, 50 charts a year, let's just do 15 a quarter. That will give us 60, and that'll give us a little leeway if we mess up. Again, there's nothing in stone or in writing. That didn't come from Moses down from Mount Sinai or anything like that. That's just what we've been using, and it's been working fine. But I know Elsie's on the phone call, so Elsie can, Elsie, we'll try to open up your line a little bit, and you can sort of get us back on track if I told somebody something wrong about this, or if you've got if you've got a number that we can use for the number of chart audits, that would be great. Okay, you got more questions before we move on?
I do.
Okay.
The second person, if a state allows independent practice of nurse practitioners, do we need to do them for RHC? And I think she's talking about the chart review.
Yeah, the answer to that will be yes. You would definitely have to do that. I think they're trying to, the RHC Modernization Act may be getting away from that, but it's not law yet. I wish it would be, because our rate would go to $115 a visit, but it's not. So you would still need to do that, even though I know we worked at clinics in New Mexico. There's no scope of practice. You know, a nurse practitioner can work independently there. We still do the chart audits every quarter. Okay, next question.
Yep, the next one says, we are hospital owned and our emergency plan is part of the hospitals. Is that adequate enough for the survey?
Typically, it's probably 90% there. What I would do is it is specific to your particular location. And if all you're doing is just copy and pasting what the hospital's done, that's not going to work. You're going to have to modify it to your particular location. So if you're located 20 miles from the hospital, what you want to do is your risk assessment has to be based upon 20 miles from the hospital. I would Google map your location and say, okay, what are the threats here? Are we right beside a major, I-75 runs right beside our clinic? Is there a big, huge dam right beside us? Are there schools all around us? A chemical plant is next door to us? That sort of stuff. You want to make your plan, your evacuation plan has to be specific to your clinic. So you're probably 90% there by using what the hospital does, but you want to tweak it to where your emergency plan is specific to you, where your response to risk is for specific to your particular clinic. Okay, next question.
Just to double check, the OIG in Kentucky needs to be done monthly. That's a question.
And that's what Patty said, and daggum, I looked up what Patty, the link, and it says monthly. It's a Medicaid, I think it's a Medicaid rule, which if you want to lose sleep at night, look through the Medicaid rules, and there's so many old Medicaid laws that are out there that are not enforced, that just stay in the books forever. So you will lose sleep if you read Medicaid rules, but it's a Medicaid rule in Kentucky, if I read what Patty said correctly. So I would do it monthly. I hate that seems like a little bit of overkill, but that's what it says.
Okay, and then the last one that we have so far is, do you have a template for the program evaluation?
Yes, we do. Yes, we do. I'll stick that on the certification. Whenever I put the actual recording of the webinar, I'll stick the program evaluation template on there for you guys. So that's not a problem.
Okay, that's it for now.
Okay, all right, good deal. What is the mindset of the inspector? Is you want to child-proof your home. If you got small children, whatever, just think about trying to make your clinic safe for your 2-year-old. You know, Dani has a 7.5-month-old, so I am sure she has child-proofed that house to no end. Think about that. Also think about privacy. Think about HIPAA. Think about, you know, saying, oh, Mark, you gained weight this time whenever you went to the doctor, which I did. He yelled at me. So you want to make sure that the door's closed, make sure it's private, make sure you don't talk too loud, and think about HIPAA as well. Who conducts the RHC inspections? Again, we talked about that, the state, Quad A, and the compliance team. Here's a presentation that Kate did, and there's a link to that, so you can get a hold of that presentation as well. I forgot to put Elsie's on there. I should have done that as well. I apologize to Elsie for that. Question 4. When the RHC inspector arrives, you should, A, send them away if you're not entirely ready. B, try to keep them waiting in the room in the waiting room as long as possible. Or C, find them a private place to work as soon as possible. Okay, this one should be pretty easy. I don't think a whole lot of you would want to have them out there in the waiting room with the coronavirus running around. Everybody in the world has the flu. We've had every webinar that we've had with clients has just about got canceled this week because every provider is just seeing the flu. I mean, all emergency preparedness webinars are getting moved back because of it. So, Dani, let's go ahead and close that one out. I think we're 97% of you guys have said find them a private place to work. Absolutely. If you're not entirely ready, I always tell people, go ahead. Depending on the inspector, you may get lucky and you may pass the inspection anyway. So have them go ahead and do it. It's not the end of the world if you have some deficiencies there. So if you're not entirely ready, just go ahead and do it, because I know we had one clinic like that. They said, well, we weren't completely ready, so we sent the inspector away. And then the next month we had a moratorium in Tennessee, and that clinic couldn't become a rural health clinic. So just have them go ahead and inspect it. You'll be surprised how well you will do on this if you've just gotten your policy and procedure manuals and if you just put that basic stuff together that we send you, you will be very, very close to being compliant. So we've had people pass. I think we had one the other day that they really were not ready, and they passed with no deficiencies. They had all of our stuff done. We'd had the emergency preparedness stuff done, and they didn't have any issue with it. So the key is there's and again, I'm stereotyping here. There's 2 types of inspectors. You can get Galinda the Good Witch, and she'll wave her magic wand and you'll pass, or you could get the Wicked Witch of the West, and she will look through every single thing in your clinic. She'll be there for 2 or 3 days, and she'll write you up. I know we had some in Alabama the other day where we had 60-something pages of deficiencies before. So they definitely, and I think they got on her wrong side very fast. They left her out with a bunch of snotty-nosed little kids for about 30 or 45 minutes, and that didn't work well. So make sure your receptionist knows that we're about to have an inspection and know how to treat them. So give them some good instructions on don't keep that inspector waiting in the lobby, get them to a place where they can work as soon as possible, have that procedure manual and that evidence binder ready for them to give to them as soon as possible, and have them their copy so they can start writing and working on it as soon as possible. Let your staff know that there is a survey going on and that they need to be on their best behavior. And if they have to do little things like check to make sure that there's still plug protectors because people steal them all the time. You may want to double check a few little things before the state inspector does show up there. Little things like that. Make sure you're double checking, make sure you're locking everything like you should be, which you should be doing all the time. But it's important that definitely during this time you want to do that. Also, call your consultant. Let us know that the state or Quad A or the compliance team is there. Sometimes, especially with the state inspectors, is they don't always do rural health clinics, and sometimes they get confused on things and they'll ask you for weird stuff. If they ask you for something weird, just remember what it is and then call your consultant, and we will tell you, okay, yes, that makes sense. Yes, we've done that before, or no, that rule changed 30 years ago. That rule changed 40 years. I mean, we still to this very day have people, state inspectors, asking for the 9 laboratory test, or they want to see that your nurse practitioner is there 60% of the time. Both of those rules changed 30 years ago, and they will still ask for those sort of things. So call your consultant. We can sort of get them on the right direction if they start falling off the wagon, or if they have something that you have and you don't know where it is or what it is. We can tell you, oh, that's where this is. You have that. Here's where to look for. Here's what Quad A will ask for when they show up there. That's their document that they'll ask for. Okay. Number 5. Will the RHC inspector, and Danny, if you open up the poll here, will the RHC inspector observe a patient visit? A is yes. Under recent interpretive guidelines, the inspector should do this. Or B, no, HIPAA privacy regulations will not allow them to do that. Okay, and we will wait just a few minutes here. 57%. Oh, you guys are voting fast on this one here. So okay, all right, Danny, we're probably running. What are we on time here? 3:52. We've got 52 minutes. Let's close the poll and then give us results.
Yep, 45% said A, yes, and 55% said B, no.
Unfortunately, the answer is A. They, under the interpretive guidelines, the state Quad A and the compliance team, they typically will have a nurse or an registered nurse on their survey teams, and they will observe you doing a visit with the patient. And typically it's 1 or 2 of those. They will ask if the patient has a problem with that, and if the patient does have a problem, then they won't do it on that particular one. But you'll find a patient that says, that's no problem, and so they will be in there. The key on that one is making sure they wash their hands correctly. We've seen so many of the providers not wash their hands correctly on that. So keep that in mind, is that they will be going in the rooms, and let your providers know that they will be going in the room with them, and don't get upset about it. It's just one of the processes that you go through. So the data survey, what will happen is your surveyor, they will tend to meet with the office manager, maybe the physician who's in charge or nurse practitioner who's in charge. You'll find a place for them to review their policy and procedures of the clinic. Then they'll take a tour of the clinic and do a walk around. They're going to look very closely on how you store your medications, what type of infection control practices you use. I mean, we do have some serious stuff going here with this coronavirus that's going around. That, I mean, it's scary what's happening there. So pandemics are very, very real. So they're going to look at that. They will interview staff and providers. They'll ask what the open-ended questions. And so what you want to do is turn their open-ended question to closed-ended questions and try to give them answer what they ask you, but don't add a bunch of extra information. I would probably be the worst person for them to ask, because I would just go on yapping forever, and that would probably get us in trouble. So they will review the patient records as well. They'll look at personnel files, and then they'll do an exit interview where they'll tell you how well you did, or if there are things that you need to improve on, and they'll sort of let you know the schedule for whenever they're going to get you a plan. They're going to give you a statement of deficiencies. And once you get that statement of deficiencies, get it to your RHC consultant as quickly as possible. And you have only 10 days to respond to that. And so you got to start working on that immediately to respond to that. And if it's condition level, then they're going to come back in 30 days and resurvey you. So you need to get started and have a good plan of correction for that. Okay, number 6. Dani, if you'll open this up. When the surveyor asks a question you do not know the answer to, do you A, pretend like you don't hear them? B, just make something up? C, say, let me refer to the policy procedure manual and get right back to you? Or D, and we had somebody in Alabama say this, I don't know and I don't care. That was the one that ended up with 60-something pages of deficiencies. So let me just tell you, D is not the right answer. And so, okay, so 100% of you guys have said C. Let's close it out because we're running out of time, Dani. So absolutely, that one was pretty easy. Let me refer to the procedure manual and I'll get right back to you. You don't have to know all those 12 inches of processes and procedures that every clinic has. And what you want to do is just tell them, yes, let me go look at the procedure manual, let me talk to the office manager or the doctor, and let me get right back to you. That's the best thing. Don't blow them off like we've had people do that. And they'll quote, I mean, I've seen this quote actually show up in the listing of deficiencies where they asked somebody a question and she was having a bad day, and now we're all having a bad day. Surveyor's approach, again, they're going to review documents and records. They're going to observe you doing things. They will watch you. I know a lot of times they'll watch you cleaning the exam rooms. They'll look to make sure that between each patient, you do good infection control and you wipe it down. You know what your contact time is or your wet time, and you do all of that stuff properly as well. And then they'll ask, like I said, they'll ask questions. They'll tend to look for the weakest link and look for the youngest one, the person who looks like they've been there the shortest amount of time, and ask them those open-end questions. That's one reason why you need training ahead of time for everybody so they can be prepared for this survey. And then, you know, being familiar with why you do something, why it's important to have good infection control. And again, here, this is what Kate had said, I would consult policy. So she's giving you the answer that we just said. And writing written reminders or visual reminders is a great idea. So we're gonna have a lot of new rules under RHCs, and here's some that Kate had done that she'd seen from some of her clinics. There is multi-dose vials. Once you need to date those whenever you open them, and they're only good for 28 days. So put up little, you know, sort of embossed reminders of that. Lidocaine, Xylocaine are single-use vials, so must be discarded between each use. There's all sorts of posters that CMS and CDC provide, so put those up so those are reminders for people as well. That's a really, really good idea. This is a mock inspection form from, I think, from NARHC from Lady in Michigan, and it's on all the public domain out there. So it is a really good, quick thing to do. I would do that about once a month or maybe every quarter. You just do a quick mock inspection. Probably take 30 to 40 minutes to go through everything and do what's on this one-page little checklist. That is an excellent idea. What the surveyors will do, they will go and look, like I said, they'll look at the patient room, the exam room tables. They'll see if there's any holes in them, or again, infection control. If they look like they're in bad shape, they're going to make you recover your exam room tables. In the waiting area, they're going to look to make sure you've got good cleaning policies. If you've got toys and books, you're going to have to explain how in the world are you doing infection control for all those snotty-nosed little kids that are sick and with the flu, and their nose is running on all those toys. It's a bad situation. Your bathroom, Typically, they're just going to look that it qualifies for the ADA, make sure there's a certain number of inches in front of the commode, make sure you have grab bars for there. I really have not seen a whole lot of deficiencies in bathrooms on tours. And then exit signs, you want to have lighted exit signs. Fire extinguishers, every month somebody should be charging that fire extinguisher, and you can do it yourself. All you have to do is take that fire extinguisher, turn it upside down, shake it, and then make sure that little yellow arrow is in the green, and then put it back on here, and then initial and date that you've done it. That's called charging the fire extinguisher. What you do there, what you want to do is it's like a cold Coca-Cola. If you have a soft drink, it's in a can, and what you do, you shake it up, and then you open it, it spews. That's what you want this fire extinguisher to do. You don't want all the stuff to be at the bottom of the fire extinguisher and it just sort of not really do anything when there's a fire. So that's called charging. So you want to do that every month. If that little yellow arrow is not in the green, you want to call your fire company, have them come out and look at it. And then of course you want to have a floor plan for the closest exit route. You probably need 4 or 5 of those in your clinic. And then you want to have your licenses, those should be posted, your CLIA number should be posted, all these state postings for OSHA, for minimum wage, employee rights. Make sure you get an up-to-date poster for that. These things become outdated pretty quickly, so you want to have those as well. And then we've already talked about maintaining your equipment. You want to have somebody come in and look at that each year, make sure they're calibrated. Before you even use them, you want to calibrate this equipment. And for your AFib machine, your defibrillator, you want to have a checklist on it where every so often, sometimes it's weekly. I've seen some people do it daily where you check it to make sure that it's operational. Sometimes I've seen them do it monthly. I've never had a real good date or time frame on how often it needs to be done. I tell people weekly, have a little form where every week you check your defibrillator to make sure, that it's operational. I need a question here. I'm running out of air. And then your medication storage here, you have to have an emergency kit. And here's a good practice here is to list out the stuff that's in your emergency kit and put the expiration date on it so you don't even have to open it. When every month you're going to check to make sure there's no expired drugs. That is a really good practice as well. Here's your sample drugs. This is something called the West Virginia system, where every month you're going to look to make sure that you don't have any expired drugs, and you're going to document that. Here's drug expiration check. That's the form they're using there, and in fact, I think that may have been our form there. That looks very familiar. So that's the form that you'd want to use for that and document that you're doing that. Laboratory services, you have to have the ability to do 6 required lab tests. So you have to have the reagents to do that. A lot of times people don't have the reagents to do that fecal blood test. And you have to have the ability to do a hemoglobin or hematocrit. We find a lot of people that cannot do the hemoglobin or hematocrit. So make sure you have the ability to do those 6 tests. Okay, update here. Let's see here. And we're almost finished. I know y'all, and thank you guys for hanging around. We still have 48 of you guys still left, so that's good. Number 7, RHCs are required to maintain snake antidote. And you guys are responding. You guys want to get out of here quick too, because y'all are responding a lot quicker than at the beginning. And we'll let it go another 24. Give it to 30 seconds, Dani, and then close it out. And give me the results.
Yep, 11% said true and 89% said false.
Okay, and thank goodness it is false. You do not have to maintain snake antidote anymore. I think at one time the interpretive guidelines that came out in January 2018, CMS apparently what the story is that the person who wrote up these Appendix G had never been to a real clinic before, so she went to the closest one that was about an hour away from DC or Baltimore, wherever she's based in, went to the RHC, and a big snake ran across her in front of her as she's walking inside. So she said, all RHCs must have snakes at every RHC, so they had that snake antidote. And she had no clue that it's like $25,000 for a snake antidote, and we wouldn't know how to use it. Thank goodness these Appendix G are not legally blinding. They can be blinding, legally binding. But some surveyors will write you up for that. I know in Kentucky we had some surveyors that wrote people up for not having snake antidote. We had to pay $4,000 to get a vial for it. So, but that's changed, thank goodness. That has changed, and we'll show you just on, I think it's on the next slide. This shows here that these interpretive guidelines are not legally binding. They're just sort of guidelines that the inspectors go by. And then what happened was the National Association of Rural Health Clinics, when they saw these interpretive guidelines, they said, we got some real problems with this. And they had a meeting, Bill Finnefrock and Nathan Baugh, Elsie Crawford. They all did a fantastic job of getting some of these things changed. Like when it first came out, it said the physician had the responsibility to review all medical records. And we're like, no, that doesn't really happen. That shouldn't be in there. So they changed that. It also said you had an outside healthcare provider that would review all of the clinical policies. It had to be a physician, nurse practitioner, or PA. And we said, no, that's not going to work in rural areas. It just doesn't work that way. So that got tossed out as well. And you had to stock it. You had to stock a snake antidote. That's gotten thrown out as well. What we couldn't get changed is the survey teams have to have a registered nurse and the surveyors must witness a visit. That is still in there. So that was the answer to that question before, is why that was the answer. And these regulations state that the medical director must practice in the RHC. And then when we called Simone Dennis about this, she's one of the people at CMS, she said, well, as long as your medical director sees one visit a year, you've met the minimum. And so I'm like, okay, that's sort of weird, sort of dumb. But if we have to, we'll have our medical director see one visit a year to meet this dumb rule. It doesn't make any sense, but that's the rule. So that's still in there. And then September 3rd, 2019, an update to Appendix G came out, and it's related specifically to these emergency drugs that we talked about. And they sort of changed, they changed the regulations now. So now you have to consider each category of drugs and you put it in your written policy, but you're not required to maintain snake antidote, anticonvulsants, whatever that other word is. My CPA-ness comes out in me there when I can't say these medical words. And there's the hot link to that Appendix G update. And then here's our question. This is our last question of the day. That means we're getting close to ending. Thank goodness. Number 8, RHCs consider which of the following when stocking their emergency kit? A, the community history. B, the medical history of its patients. C, accepted standards of practice. Or D, all of the above. And we'll give you just a few minutes here. You guys are voting. Y'all really want to leave, don't you? Which I don't blame you. Get my drink of water here while we're waiting you guys to vote. All right, Dani, you can close it down.
Okay.
Okay. And give me the results.
Yeah, 10% said C, and then 90% said D, all of the above.
Yeah, and the answer should be D, all of the above. And the reason, here's where we got the answer from that. If you see in red here, I just basically copied and pasted from that interpretive guideline letter. The RHC should consider, among other things, community history, the medical history of the patients, and the accepted standards of practice. And so medical history of its patients, think about if you're a pediatrician, you're going to get one type of, you should have sort of one type of medicines for your emergency kit, and your emergency kit will be completely different if you're internal medicine and you've got a bunch of older folks. So think about that. Also think about the competencies and the things that you'd feel comfortable in providing. Think about how far away the emergency rooms are or the hospitals are from you. If you're 25 miles away from the closest hospital emergency room, you may want to have a more robust emergency kit. If you're on campus of a hospital, then you probably need to have a bare minimum because you're just basically flushing money away. Appendix Z, this is for emergency preparedness, that was revised 2/1/2019 as well. And some of the things that relate specifically to rural health clinics were in your all hazard risk assessment, you want to add infectious diseases. And you probably didn't think too much about that before, but now with this, what's it called, coronavirus out there, I mean, really, the feds and the states are very, very serious about this, and with good reason. I mean, this could kill a lot of people. There's like 50 million people died in, what was it, World War I, from not from the war, but from the flu, the pandemic flu that went around. So this thing, it's very important. You want to make sure you put this in your risk assessment. If you don't put it in your risk assessment, a lot of times I've gotten written up here recently because we didn't have infectious disease in there, and so I'll typically put that 5th or 6th on my list of risks that are in my risk assessment. And you want to have a policy. We've developed a policy that we put in there related to infectious diseases. So you want to have in your emergency preparedness manual a policy on infectious diseases. Okay, resources for RHCs. Here's where the regulations are. Here's Appendix G. Here is CMS Survey Form 30. This was last updated March the 1st, 1978, but a lot of your state surveyors will still use this form that's not been updated. That's why you get a lot of bad information sometimes from the surveyor, and you have to sort of go in correction mode with them. We don't have that same issue with Quad A or the compliance team, but the state surveyors. Here's some of the things that have changed over the last 40 years that they will still cite these as well. So just like I said, if you have a problem, let your consultant know, and they usually can fix it pretty quickly with them. Here's how you can get a hold of state surveyors. There's a listing of those. Quad A, here's LC's website there for Quad A. The compliance team, there's Kate Hill's website to get a hold of them. And each one of those have standards. What you want to do is look at the Quad A standards and the compliance team standards, because they're a little different than what the SOP is, the state operation plan is. They're a little different, but you want to take a look at those and make sure you're complying with those as well. There is some good education out there. This thing is real new. It's called QSEEP. It used to be under a different place. As far as let me see, the two things that what I've used before was RHC training module. There's about 25 hours of training to become an inspector. If you click on this link, it will actually take you to this website right here, this QSEEP, and then within it's called the Quality, Safety, and Education Portal. And you'll have to get sort of registered and get credentials in order to get into it. I haven't got into it yet, but I know we've got some of our providers that are getting into it to get this type of training as well. That's for your if you want to be an RHC surveyor, if you want to work for LC one day, go through that training. That will be very, very helpful to do that. I've gone through the RHC modules. It's probably been 2 or 3 years since I've done it. And then here's your emergency preparedness module there. There's about 16 hours of training through that. I've gone through that as well. Probably by now, it's probably time for me to redo it as well, because everything gets a little bit old. Here's some of the forms from Idaho that they use. There's a presentation every year. I think all the consultants don't want to go to Idaho because it's such a long way. So, okay, every 5 years or so, I'll get stuck being the one that has to go all the way out to Idaho. Though it's a beautiful place. It takes up 3 days of your life to go out there and tell them about rural health clinics. But here's some good forms from the meeting a few years ago that are really good. And then deficiencies. Here's what happens. Here's some of the major deficiencies. There's something called Q-Core. And if you go into this website and for some reason it's not working today, I tried to update my slides today. It would just freeze every time I would go to Q-Core. So they may be having, they must have some type of virus themselves. But this will give you active RHCs in your particular area. That's something that's very good. And they actually give you a listing of deficiencies for your particular state. So you want to take a look and see what the surveyors are finding in your state. And again, a lot of it, the big ones that we see are no program evaluation and emergency preparedness is not up to date. Those are the 2 big condition level deficiencies. You can see a physical plant and environment. A lot of times you're not doing your preventive maintenance or not paying that money for the biomedical company to come out and look at their stuff every year. And this was one that we had 3 clinics in West Virginia that we work with noticed that they risk assessment, and these guys spent they didn't use us to do their emergency preparedness. They used somebody else, and they spent $40,000 on emergency preparedness for their clinics. And every single one of them got written up this time because it wasn't updated. So they basically spent 40 grand, and every single one of them got a deficiency. So we had to go back and redo it. We had to go back and just update everything. We had to redo. The company did a really good job. It just wasn't updated. And then again, hand washing. We had to go and watch this. I've watched this hand washing video probably 10 times in the last year, because whenever you get deficiencies, you have to do an in-service for your employees. And so we ended up watching a hand washing video at least 10 times in the last year. And then here's some of the quad A deficiencies that have been listed here. Consent to treat is a big one. Drugs and biologicals not being properly stored. We're running out of time here. I won't read you all these, but you do have the slides, so you can go through this. Okay, questions, comments, being able to open up the lines here. Let me see. Dani, do you have some questions for me?
I have one, and I have 2 comments. Elsie says, Mark, all of your answers have been spot on.
Yay!
And then David Cantrell says, first inspection took 1.5 days. The past have taken no more than 3 hours. Key is the 6 P's. Proper prior planning prevents poor performance.
Sound like someone Navy man would say right there. So,
and then one question was, is the AED a requirement?
To have an AED in most states, it's not. There are some states where I think Alabama requires an RHC to have an AED. Other states, I don't think it's a requirement. It's sort of a state by state.
From Kentucky.
What's that?
This person's from Kentucky.
From Kentucky. I'm going to open up, Elsie, if you don't mind. I'm going to open up your line in a minute, and you can help me. You can help me with that one. And I'm not sure if it is or not. Do you have any other questions before we open up Elsie's line?
That's the last question, and Elsie's got her hand raised, so I think she's ready.
Okay, all right, Elsie, we're going to open up your line, and we're going to give you, the floor is yours, as they say. Let's see here. Okay, hey, Elsie, your line's open. Hey, Elsie, can you hear us? I don't know. Elsie, your line is open. Okay, now you've muted it yourself, Elsie. If you unmute your line, you'll be able to talk. Just click on the little button. This is like bad radio at this point. Okay.
She says my microphone isn't working. I'm sorry.
Oh, okay, alrighty. All right. Well, all right. Well, we'll. Hey, Elsie, can you type in whether is an AED required in Kentucky?
No.
It's not. Okay, it's not. Okay. Thank you, Elsie. Thank you. Okay. Well, next time we'll make you a panelist, and we'll get your microphone working for us, because we need to get you to help us do these things. So
you said it is a good practice, though.
Okay. Good deal. Good. It is good practice. Okay. Perfect. All righty. So no more questions. Dani, any more questions on that?
No, sir.
Okay, and do we have anybody that's got their hands up wants to open up the line? I don't see any hands up. All right, everybody, thank y'all very much. I know y'all been overwhelmed with webinars recently. We've tried to get all of our materials sort of updated, because we're about to go into cost report season. So that's why we want to get all of our sort of webinars updated, because the information was getting sort of stale at this point. We try to update them about every year or so. So you probably won't see a whole lot of webinars for the next few months, because we're going to be preparing cost reports. So if we're working with you guys on your cost reports, try to remember those things. The sooner you get them to us, the better off we'll be. And thank you guys very much. Dani, thank you for your help. Elsie, thank you for your help. And we're going to close it out for everybody. Thank you all very much. And end webinar for all. Thank you.